Good afternoon, everyone. I'm going to call to order this meeting of the Health, Environment, and Community Engagement Committee. I'm the committee's chair, Councilmember Gordon, and I'm joined by Council Members Fry, Bender, Andrew Johnson, and Cano. Councilmember Glidden won't be here today. She's out of town, and Councilmember Johnson's going to be leaving potentially a little bit early for a doctor's appointment. But 4 is a quorum, so we should have a quorum of the committee through the entire committee. We have 5 items before us today. The first item we'll take up now is a public hearing regarding restroom facilities and an ordinance amendment. And before we open the public hearing, we will have a brief staff report from Ms. Cindy Weckworth. Welcome.
Whoops, try not to break it.
Oh, just no problem.
My name is Cindy Weckworth. I'm with the Health Department. I'm one of the supervisors in the Food, Lodging, and Pools program. Today we're here to talk to you about proposed changes to the Food Code Ordinance, the Liquor and Beer Ordinance, as it relates to toilet and restroom facilities. The chapters that are affected are the Chapter 188, which is the Food Code, and in this particular section, we're looking at repealing the language in Section 450 that references toilet facilities required. We're looking at amending the language in Chapter 364, the liquor regulations, also related to restroom facilities. And then in Chapter 368, the beer regulations, also repealing the toilet room facilities requirements. These changes are recommended as the text in all 3 of these chapters is redundant. The language already exists in the state food code and the building code. It addresses such things as the fixtures that are required, such as toilets, toilet seats, urinals, the sort of room finishes in the toilet room, the requirement for hand washing sinks, lighting, doors, gender-specific requirements, and the exception for language that we're leaving in is a piece associated with floor drains. The food code already requires floor drains in restroom facilities, but the plumbing code does not, and therefore this language is staying in for on-sale liquor and beer facilities. There's one piece that was added to 364, which is the liquor regulations. This is to add language referencing that restroom facilities must comply with applicable code, statute, rule, and regulations in the on-sale liquor or beer establishment. So essentially it's combining those pieces to add that reference to the state codes and also add on the or beer to liquor establishments, and you have that language in front of you. Both the Minnesota Food Code and the Building Code are currently under revision. As it exists, the city code would need to be amended to adopt any new language that's adopted at the state level. This change to the city's ordinances allows any revisions at the state to be automatically incorporated. And it also, in essence, gets the city language, which has been present for a long time, kind of out of the way of changes that are being proposed in the 2015 building code that are more friendly to small businesses and to families and people needing accessible toilets. For instance, in the 2015 building code, the trigger that impacts the number of required toilet facilities has changed. That trigger is associated with the square footage requirement and the occupancy, and the changes for businesses such as retail stores, service stations, small markets, and these type of facilities or establishments have changed so that there'll be a less onerous requirement for number of facilities on small business owners that have a small space. They'll be able to use, I've put a picture up here of one of the signs, a facility that's called a family/assisted use toilet facility. These are gender neutral and can also be used to meet the requirement in larger facilities where currently the code says you need to provide a toilet facility for both sexes. These can be used in replace of that. And they're seen as serving both a mix of family and personal needs, facilities that can be used by either sex, eliminate the need for queuing up, which seems to especially happen at the women's bathroom, and coming from a family of 4 girls, and it seems like that was always an issue, and this allows for both facilities to be used by either sex. It also provides a compassionate solution to our residents and guests who are transgender, who are providing for companion care, for parents using diaper changing facilities who may have one restroom tied up, maybe the women's restroom. Then if these are both unisex, then there's more options available to our residents and our guests. And also if one of them is out of service or is being cleaned, then there's not the need for one gender to queue up while they're waiting for their toilet room to be cleaned. So it's really kind of just a practical solution to some issues that exist. It solves, I think, a number of concerns and problems that are out there, and we ask that you move forward with these changes. And if you have any questions, you can contact me or Pat Higgins with the building official.
Or we can ask right now, even if any committee members have any questions, we can do that if you want before the public hearing. I just wanted to ask if I heard correctly about the 2015 building code. So we think the building code is going to be much more open and it will not be requiring any gender specific restrooms?
Well, no, that's, I'm sorry if that may have been what it sounded like.
If Mr. Higgins wants to answer, he can too, because
sure.
He's our building code expert, I guess.
Good afternoon, council members. Pat Higgins, building official. What we're going to see in the 2015 code is going to be a relaxing of the requirements in single-use restrooms. So in small occupancies where you have a single-use restroom, door can be locked, then the opportunity to make that gender neutral is going to be afforded to those folks. As far as your larger venues where you have more than single-use restrooms, those would be still gender specific.
Okay, I appreciate that. Will there be any requirement for a single-use restroom in buildings of a certain size or use?
Not sure if I understood the question.
Well, I'm assuming that there is some requirement for a certain number of toilets depending on the size of the building or the uses in the building. Is that right?
Yes, that's still going to be based on the number of occupants that are using the space.
And is there at any point where they will require a companion bathroom or a family bathroom or a single-use bathroom?
Yes, and that will be determined by the number of restrooms that are required or the number of facilities that are required. So as you get into your larger venues, there will be, after so many rooms, then they must provide a, get this term right.
Yeah, I'm not sure what to
family assisted, family or assisted use restrooms will be required when you get to the larger venues also.
I appreciate that. I'd be curious as to if we just looked at some of the city city buildings that we have now, like if City Hall was being built then in 2016, if we would be required to, and this can be a rhetorical question for now. I don't know that you know exactly what the occupancy is of the building and whether it would be, but it would just then be interesting for us to look at some of our buildings and say, well, maybe we should retrofit ourselves to meet the new standard. But well, thank you very much.
Agreed.
And seeing no other questions, I'm ready to open the public hearing, and I don't know if anyone is actually signed up. Well, I'm going to open the public hearing, and if you'd like to speak, just stand up and come up to the podium there and introduce yourself. Is there anybody here who would like to speak on this issue? Hi, if you could introduce yourself with your name and address.
Yep, Tom Degree. I live in Lake Elmo, Minnesota, but I own a restaurant called the Wild Rose Cafe in Northeast Minneapolis, co-owner of Maddie's on Main, which is also in Northeast Minneapolis. I'm just here to come to talk as the business aspect and economic. I'm sure you're going to hear the more human aspect after. Business aspect, 10 years ago, we opened up the Wild Rose Cafe. And because of a coffee shop size, we were able to have 2 non-gendered bathrooms. And we were able to work well with 2 non-gendered bathrooms. A lot of the trans community found us as a safe place. And for as economic, it's nice to be able to have people to have a safe place. And the Wild Rose Cafe became that place 10 years ago. 3 years ago, we moved to the riverfront in a pre-existing restaurant that had 2 predetermined bathrooms. And a lot of the people from the trans community didn't feel as comfortable, and they voiced their opinion. So economically, it changed as far as where they would feel comfortable going. So what happened is, go forward 3 years to this year, we opened up Maddie's on Main. And so when we had complete opening of how to design the bathrooms, we wanted to have 4 non-gendered bathrooms. And we were told by the city we needed to have very specific bathrooms that had male, female on them. And for a small business owner, I think I should be able to make the decisions on whether my bathrooms are non-gendered. If they're single, locked door, 1-person stalls, that I wanted 4 of them without having to have gender on them. Makes it comfortable to trans community, but also, as we heard, it makes it comfortable to women that don't have to queue up for a bathroom when there's 4 bathrooms available for everybody. So as far as economically speaking, business owner speaking, I like to be able to have that freedom when I build a restaurant in Minneapolis. Also, I like to have the communities of all sorts in Minneapolis feel welcome in my place. Economically, obviously, we're looking at a business that needs to make money. If those people or every people of any want to come into our place, I just want everybody to feel comfortable. And I'm not speaking just trans community, I'm speaking of women, men. Everybody would feel comfortable coming in because of the bathroom availability. And also it has gotten out there that we are setting precedents at the Maddie's on Main of having non-gendered bathrooms. And it has come off welcoming. We've had no issues with it. No problems with people wondering which bathroom to use. Nobody feeling uncomfortable because their door locks. So as far as business, economic aspect, I think it's better for Minneapolis to get rid of this. When we opened up and went through the process in April, May, we just went forward and did it. So hopefully change it today.
Well, thank you very much.
Yep.
And just because we pass it in committee today, if we do, it still has a few more hoops to go under, but I don't think anybody's going to come out after you. Sir, yeah. Anybody else want to speak on this matter? Welcome.
My name is Dylan Flunker. I live in Minneapolis, Ward 2, and I'm transgender, and I'm also the parent of a 3-year-old. And so I came out to my family and friends as transgender and started living as male in 2008. And before I was able to medically transition, had a lot of uneasy bathroom experiences where even when you want to use the appropriate restroom for your gender, people are like, what are you doing in here? And then also still presenting more masculine, not being welcome in women's restrooms either. So there was definitely a very uneasy 3-4 year period of my life where going to the bathroom in public was just not something that I did. It's exciting now that I'm able to, but now that I have transitioned and that I'm a parent, I'm finding My daughter is being potty trained currently, and when your 3-year-old has to go, your 3-year-old has to go to the bathroom. There's no negotiating about that. So I found that the places where we're able to go into single-user stall bathrooms are the easiest for us to access in public when I'm out with her. My partner and I share care during the day a lot, so we frequently are out during the middle of the day needing to access a restroom. Being able to get into those bathrooms is incredibly beneficial when you haven't quite figured out underwear, pants, all of your things when you're a little child. You need assistance still, and it's very hard to do in stalls. And even when she was an infant, men's restrooms are not known for their cleanliness or always their baby changing tables. Single-use bathrooms that are accessible for families greatly increase the capacity of families to be out in public with their young children. So thank you very much for your time, and if you have any questions, great. Otherwise, I'll let other people speak.
Thank you very much. I don't see any questions. Is there anybody else here to speak on this matter? Welcome.
Hi, thank you very much for having me. I appreciate it. My name is Claire. I'm male to female transgender. Just came out this year. I've only been transitioning for about 5 months now. So I kind of have a new perspective on it as well as an old perspective on it. As well as being trans and having 3 children, my 3 children are disabled. So I kind of cross the lines of being transgendered and being a parent of children with disabilities. I'm also still married to my wife of 18 years, so that should continue. Anyway, with the obvious issues of me being transgender and using gender-specific bathrooms, I have problems in both of the bathrooms where I have been accosted or I have been threatened in male bathrooms, and I have been yelled at, and I have been peeked through the doors in female bathrooms. So technically, I'm not really allowed in anybody's bathroom. That's in Minneapolis. Out in the suburbs, the 2nd tier and the 3rd tier suburbs, they all have gender-neutral bathrooms, or they have the family restrooms. So I have no problems going to any mall in Minnetonka or Hopkins or north or south suburbs. Walmarts, Kmart's, all those things, they have family bathrooms. The minute I walk into the city, and I live in the city, or I don't live in the city, I work in the city, and I bring my kids to a lot of the games, and concerts down here. So once you hit the cities and you hit the concerts and you hit the stadiums, you have these gender-specific bathrooms. As I said, all 3 of my children are disabled, my oldest being 14, and I need to accompany him. They're all males, they're all boys, 8, 9, and 14. I have no problem taking my 8 and 9-year-olds into the women's bathroom, but when I have to take my oldest son, the 14-year-old, I have to go into a men's bathroom because he's not going to go into the women's bathroom, and they don't want him in there. And he's a 14-year-old that looks like a 17-year-old, but is working on a capacity of a 6-year-old. So I do have to go into the male bathroom, and I have to either be in the stall with a 14-year-old, or I have to wait outside of the stall with a 14-year-old, and you have issues that begin there. So, so it would really, again, not having these problems out in the suburbs, but having them within the city limits of Minneapolis, I think it's time that Minneapolis caught up with the suburbs and did what needed to be done. So thank you very much for allowing me the time to speak. I appreciate it, really. Thank you.
Well, thank you very much for being here and sharing your unique story. Is there anybody else who wants to testify today? Seeing no one then. Nope, you're okay? Okay. Then I think we're ready to close the public hearing, so I'll close that, and we can open it for discussion here or a motion from the committee. Councilmember Johnson.
Thank you, Mr. Chair. I would like to move forward these proposed ordinance changes.
Fantastic. I appreciate that. And I'll just make one comment. Because I had an opportunity to recall some experiences in my own life, and I've been a parent, and I've had young daughters, and I've noticed this challenge in a lot of places. And then I also had an aging mother, and I would take her, we'd go on outings and road trips, and she was in a wheelchair, and she needed assistance after she had her stroke. And I actually remember an experience in the suburbs, incidentally, where We had to then go to a men's restroom so that I could help her because there wasn't really an alternative and an option. And it's very awkward in the small stall, even the handicap stalls and all that. So I think this is a great step forward. I really appreciate Councilmember Johnson for bringing this up. Actually, he brought it up before he was elected and started organizing around it. And finally, we're getting the work done now that you got here. So I appreciate that very much. And Councilmember Bender.
Thank you, Mr. Chair. I just wanted to briefly voice support for this ordinance change. Thank Councilmember Johnson for bringing it forward, and thank everyone for sharing their stories today and supporting this. This is something that came up for me as well when I was talking to my neighbors during the campaign. More than one person raised this issue with me, so I'm really glad to see that we're getting it done. Thank you.
Councilmember Fry.
Thank you, Mr. Chair. I hate to beat the horse to death here, but this is a really great step forward. Thank you, Councilmember Johnson, for bringing it to our attention and bringing it forward. This is much needed, I think, both in terms of for a social initiative, for fairness, for inclusion and equality, and also from a business perspective. It simply just makes common sense. So thank you. I'll be voting in favor.
Councilmember Johnson.
Well, thank you, Mr. Chair. I don't want to reiterate all these points because I just thank everyone for being here, though, and it just is a great ordinance to change for all of these reasons. And I know that I've run into businesses in my ward that have been affected by this, that have had this ordinance required. I know for some business owners, this is actually a cost savings. For others, this is about economic activity and drawing more people. It's so good for just anybody who's ever had to needlessly wait for a restroom, and then for all the far more important reasons that were mentioned today around both transgender issues and also the assistance ability for the disabled. Is just a wonderful change, and I'm really happy to see the folks come out today in support of this. So thank you.
Thank you, and I actually hope this will cue up some changes into the future. It's great to hear about the new building code, but I also think it's time for us to figure out where is that companion single-use bathroom going to be in City Hall. Let's figure that out and get it put in here. And then let's look at all the schools and the parks and the other public buildings and the libraries out there who don't have any alternatives, and how can we start thinking about let's get that taken care of. So, and especially, I guess, the place to start is in the city-owned buildings, so maybe we can work on doing that. And I do know there's a task force that's been looking at City Hall and what we can do, and the policy aid from the 8th Ward has actually been a part of that. So looking forward to that. But on this great ordinance amendments, all those in favor, please say aye. Aye. All those opposed, say no. That motion carries, and that matter is done. So we can move on to item number 2, and thank everybody who came. You're welcome to stick around or to go on with your lives elsewhere too. I appreciate you being here and your support for this. The second 2 items are both consent items, so we don't have to have any discussion on them unless any council member wants to, and then we can. The first one is authorizing a contract with the public schools to accept estimated revenue in the amount of $3,900 for mental health services and sports physicals at our school-based clinics. And the third item is to set a public hearing for October 20th to consider the subject matter of an ordinance amending Title 10, Chapter 203 of our code relating to the food code, grocery stores, and specialty food stores. Anybody want to discuss either of those items? Seeing none, then I will move both of those items, and if all those in favor, please say aye. Aye. Any opposed? Those motions carry. And now we have 2 items left, discussion items, and the first is finance and property services and regulatory services and CPED in the health department. Matter relates to all of them, but we're going to be hearing from Mr. Dan Huff having to do with our 2015 license fees. And whenever you're ready, Mr. Huff, you can kind of tee this up. We're going to actually be asked to approve no increase. In this matter will be referred to those other committees too, but we also want to hear a little bit about plans for the future. Welcome.
Thank you, Mr. Chair, council members. My name is Dan Huff. I'm the Director of Environmental Health within the Minneapolis Health Department. I am joined today by my colleagues Grant Wilson, Head of Business Licensing in CPED, and Lee Larson, Manager of Finance within Regulatory Services. Basically, our license fee schedule is how we determine the fees that we as staff charge for all sorts of businesses within the city. Those include rental licensing, your bars and restaurants, your pollution control fees, a number of fees. Anything that's not a construction-related fee, like a permit, would be found in this fee schedule. Sorry, I should have ordered from Cindy on that one. Each year you set this fee, and the idea of the fee is that it covers the cost for the services the city provides. We basically have three choices. We can not provide a service unless it is mandated by state law. We can bring in the revenue elsewhere, like property taxes, or we charge the business for the fee that the business receives. So examples are all the inspections that we conduct of businesses, the support that businesses receive from police, fire, public works, all of our administrative costs, which include processing of licenses and meeting with folks, as well as all the back-end administration, our city's HR, city's finance, our fleet services, all of the support services that support our inspectors and police in the field. And then we also provide numerous types of technical financial assistance, our wonderful partners in CPED with things such as the Business Technical Assistance Program and other types of things that we provide for our businesses. Kind of give you an idea of history of where we are. What we usually do is just kind of move forward perfunctory with a 3% fee increase. And that didn't really seem to jive. So as policymakers, we work with you to make sure that the fee we request is actually commensurate with our costs. And we take a lot of other factors into account as well. So you can see the history here. During this amazing recession we had, your predecessors and Chair Gordon, you on the council decided we really needed to lighten the load somewhat for businesses. And so over the last 5 years, we've actually only increased general licenses by 3% and haven't done any increase on taxi fees. But you'll see that our city costs, which are kind of in line with inflationary costs, have increased by 9.5%. So our license fees have not kept pace with city costs to provide services. And if we had gone with just a flat 3% increase each of those years, we would have brought in $1.2 million in revenue above what we have brought in now over that time. So our recommendation, given that, is still for the 0% increase, which doesn't necessarily match the data I just presented. But the reason is this. We want to take this time to really overhaul our fee schedule. Like all nice big fee schedules, or think of the federal income tax code, things get added on over time, and you kind of have drift in policy and why fees were established when. And it's time to look at this. And three things are driving it. One is we want to integrate with the new enterprise land management system. We currently use a lot of different software systems to track some of the same things. All of this is going to go into one system, and so all those fees need to account for that. We just got a lot of administrative work to do on that. It's also time to conduct business process improvement. We have 9 different licenses for meat markets. Probably we just need maybe 1 or 2 license categories for meat markets. We have some things where there's only 1 license, and there probably should be more. We need to get under the hood and clean up the fee schedule. And it's really all to ensure that the fees we charge are commensurate with the services we provide. So a good example here is Target Field. Target Field has a liquor license that covers the entire establishment because you can walk around with your beer, from one stand out to the seat or wherever. The problem with that is we, as the health department, inspect about 150 different places within Target Field, all the stands, all the portables, everything, all the restaurants. But we charge Target Field as one restaurant, basically. So you may have a bar downtown that pays almost the same fee as Target Field, and yet we spend a lot more time inspecting Target Field, as you can imagine. We need to make sure that the fees that are charged meet the needs, so you can do a license fee for liquor over the entire establishment, but can then still account for the work that the city does inspecting that facility. So we want to incorporate the following. First, a tiered rental license fee, and Lee Larson is from Regulatory Services. If you have questions, she can address that. We want to put into a risk-based food license fee. State statute determines how often we inspect a restaurant. That is determined by its risk category. We do not account for that staff time within the license fee schedule currently. We want to change and add a sponsor fee for short-term events and to provide some flexibility with events like beer gardens. So every single beer vendor doesn't have to be licensed, but we still have accountability through a single sponsor license. I mentioned the stadium issue, the same as with hotels. You have a hotel that has 201 rooms, pays the same fee as a hotel with 900 rooms. And we want to make sure that there's more of a equity between the complexity and the size of an establishment and the fee that we charge. And as I said, we're going to clean up and simplify. We also would like to round all of our fees to the nearest $5. Because we do percent increases, we end up with like $137.48, which is just weird, and we'd rather just round it to the nearest 5, and that's how our finance system adopts it anyway, incorporates it. So the idea is next year we'll be up here and we'll present a brand new, shiny, really interesting fee schedule for you. Because we have not raised fees for quite a while, there are going to be fee increases that we will propose next year, but those fee increases will hopefully be much more targeted, much more equitable. We'll be able to really outline the services that are provided for that. So, questions?
I have a couple questions. The staff report makes reference to a wholesale sausage manufacturer license fee.
Yes.
I didn't notice that in the PowerPoint. Is that something we actually have? And can we get rid of it?
Mr. Chair, yes. I didn't call that one specifically out. That's part of our cleanup. We need to work with the Minnesota Department of Agriculture to determine. We've gone back and forth. We have, I believe, only 1 or 2 establishments in the city that have that license. Minnesota Department of Agriculture generally licenses wholesale meat places. We've gone back and forth with them as to what the appropriate. We would like to just get rid of the license and let MDA license that facility. You mentioned meat. One of the fees we'd like to remove, our license categories, is horse meat dealer. Once again, that would be under the purview of MDA, and we have not had a horse meat dealer license in the city for as long as our records go back.
Okay, and maybe we hopefully won't have one anytime soon. I also noticed in the staff report, it says that we're supposed to have, looks like, prior to September 1st of each year, the appropriate committee shall conduct a public hearing to consider the adjustment of all license fees.
Yes.
I don't believe we had that.
Mr. Chair, no, we have not, and we are late this year. Part of the reason we are late is we started to look and see if we can do all these things I just mentioned for this year and realized we couldn't, and then we got a little behind. Now this is, we will be conducting the public hearing tomorrow. We have worked with our city clerk and believe we, hopefully will beg your forgiveness for being tardy on that. Interesting to note, the reason that we have that in ordinance is because one land management system right now, Kiva, requires us to manually go into the code, the coding of the software, the database, and change all of the codes, which just takes all the fees, which takes a really long time, which means we have to adopt the fees really early, and that's why we had the September 1st deadline. Hopefully with the new enterprise management system, it's going to be a lot quicker and less time intensive.
So the public hearing will be held at Community Development and Reg Services Committee tomorrow afternoon?
That is correct, sir.
And probably if it'll be a short public hearing if we're proposing an increase of 0%, and probably won't be a lot of objection, and hopefully nobody's going to take us to court because we didn't finish it by September 1st, right? Okay. Well, I appreciate that. I do appreciate that this is a lot of complicated work that we're going to have to get done next year, and I think it might be smart to try to brief council members outside of the committees even about what the changes are going to be and where they're going to be, because there's lots of different pieces. But I don't think we have to dig too much into it today, and I don't see any other questions. So I will move then approval of a 0% increase and to receive and file the report. Any discussion on that? Seeing none, all those in favor say aye. Aye. All those opposed? That motion carries. Then we have one item left, which is interesting. Thank you, Mr. Huff, and everybody for attending. This is from the Health Department, and I believe that our Commissioner of Health, Gretchen Musikamp, will be presenting to us on the health disparities in the city of Minneapolis. Welcome.
Thank you, Mr. Chair, members of the committee. Can you hear me all right? It's been kind of variable in the auditory.
Yes, we have a brand new system here, and I'm not sure whether I can hear you fine now, though.
I can hear myself, so
I hope
that's a pretty
everybody
good
can
sign.
hear me as
all
well.
Right. Well, I'm going to just give you sort of a taste of some of the data that we collect looking at health equity and health disparities, and I'll talk about the difference in those two terms. And but first I want to start with a slide that I hope you will look at and remember, because I'm going to refer to it as I go, and I'll have another one at the end. About 15 years ago, in the public health world, we began to talk about social determinants of health. Up until that point, I think we'd thought of things like your genetics, maybe, how you acted, if you went to the doctor. Those are some of the things we thought that determined health. And more evidence is that there's a whole bunch of other stuff that probably makes more difference than some of those things I just mentioned. Where we live, what kind of income we have, how much education. These are very powerful determinants of health. And so this was news, sort of, to the public health community about 15 years ago. We began to realize that it's in this area that probably most of our disparities or inequity come from, is inequity in those social conditions. Now, I say it was news to public health because I think it was not news to anyone in the community who knows, well, yeah, if I don't have much income, it's harder for me to follow the advice of what I'm supposed to eat and find time to do the kinds of things that are good for my health. So I think public health is catching up with the community, and hopefully as the coming together of those two ways of knowing, we can make a difference. So oftentimes when we talk about health, people think health care. If I go to my doctor, if I have health insurance, that's good. I'm good to go. Studies show that only about a high of 20% of our health probably comes from whether or not we have health care. I think of it as more of a finding problems and fixing problems, maybe getting some health advice. Another area we think a lot about, I think, is health behaviors, and that's about 30% of our health is determined by health behaviors. And even health behaviors are determined somewhat on our contextual environment. So while we might be very smart and well-intentioned about our health behaviors, it's not always easy to exercise them. The fourth area is physical environment. So certainly how healthy our air is, but also are there things nearby where I can ride a bike or exercise some of my healthy behaviors. And then the 40% that I was talking about, the socioeconomic factors. And I think we, as having public health embedded in government, I think we have some really special tools because there are so many other parts of the city that can be leveraged to influence health. So as we think about how does public health go about doing, public works go about doing their business, and how can that create a better environment or help people live out the healthy behaviors they would like to exercise. Or CPED, how are our economic development efforts supporting health and income in our community. So I feel really privileged to be practicing public health in the context of a city. And of course, our community partners are equally important. So the next slide, I want to talk about a couple terms. As a department, we have a vision, which is healthy lives, health equity, and healthy environments are the foundation of a vibrant Minneapolis now and into the future. We used to talk about health disparities, and you'll still hear that term raised. Disparities are the differences in health among distinct population subgroups. But we're more often now to talk about health inequity, which is health disparities that are the result of systemic, avoidable, and unjust social and economic policies and practices. And so as we as a city think about our city's equity work, I think it really is well connected to health equity. So some of the social determinants of health have to do, one of them has to do with poverty. And so you'll see the slide on the right is the concentration of highest poverty, and on the left, concentrations of people of color. And we have done some special coloring in, so the darkest colors are where those two factors both exist. And so you'll see, to no surprise, North Minneapolis and parts of central Minneapolis. We see health inequities distributed in much the same pattern. As we look forward in time, I think it's important for us to look at how the demographics of our city are changing. And you'll see that people ages 0 to 17 are much more likely to be residents of color than those over 75. And so if we're going to be a healthy, vibrant city in the future, we need to pay even more attention to equity and the causes of disparities. This next slide shows how connected we are to the world. You'll see that there are people in Minneapolis from just about all over the world, and the larger the dot, the more folks came from that area. And so we need to think both about, when we think about equity issues, we need to think both about those who have lived in this country or this community for many generations, as well as those who are coming from other parts of the world. So today in this presentation, I'm really just going to give you a sampling of some of our efforts to address health inequities in the areas that are listed on this slide, but I will go through each one slide by slide. The first one is teen parenthood. And you'll see the darkest part of the column are mothers 17 or younger, and we've seen a significant decrease, 67% decline amongst young teens. And the lavender parts of the bar are mothers 18 to 19, and we've seen a 43% decline in that area. We've used a variety of strategies. Youth development, which I think fits in that socioeconomic area, that 40% area. We also have school-based clinics. We pay for home visiting by nurses for all teen moms. Those, I think, fit in that healthcare access, 20%. And then we also have been doing a lot of work to make sure that comprehensive sex ed is available in high school and middle school and community venues, and that would fit in that behavior quadrant.
Can I just ask a
Yep.
quick question? If anybody knows, were there population changes in the number of girls who are 17 and younger, or 18 and 19? So the numbers have obviously been decreasing, and we're looking at a decline in percentage from previous years. But I'm just wondering if some of that is due to a decline in the population of those age groups, or is it really as good as it looks?
I thank you, Mr. Chair, for that excellent, insightful question. I'm going to turn to my statistician. Are these raw numbers or are these rates? Oh, I'm going to turn yet again over to Ms. Pat Harrison.
Chair, this is Pat Harrison from the Health Department. We put it in raw numbers because sometimes when you look at rates, people don't have a sense of how many young women and families really need to be served. But the decline in the rate is very similar to the decline in the number. So this isn't just because there are fewer teens in Minneapolis, it's because the rate has actually gone down.
So we basically have the same number of teens?
Pretty much.
Well,
it hasn't changed a lot. I mean, the only way to estimate the number from year to year is with the American Community Survey, and that is an estimate. We have no way of counting teenagers every single year. But within the margin of error of that survey, it's really pretty consistent.
Okay, then it is good news. Except for that 123 and 123, that leveling off the last couple of years. We got to work on that, but anyway.
Yes, we have 123 people to work with. The next slide looks at teen pregnancy a slightly different way by race. And one important thing to look at is if we are focusing on diminishing health disparities or health inequities, we want to make sure that the difference between those with the highest rate and those with the lowest rate get closer together. And so the gap between the lowest and the highest groups over the period of time on your slide there has narrowed by 52%, which is something to be happy about. The fact that there continues to be a gap is something to be challenged by. Okay. The next area that I want to look at is infant mortality rates. And infant mortality, looks like there's a question, Mr. Chair.
Oh, sorry. Councilman Fry, sorry.
Thank you, Mr. Chair. Would you mind switching back to the previous? Yeah, there you go. I don't have a question. That's pretty amazing, though.
Okay. Yeah. Thank you. So the slide on infant mortality, I wanted to focus on this because infant mortality worldwide is really a sentinel indicator of community well-being. And so it's important to look at for us and for the people living here, but it's also a reflection of how things are going overall. So the actual numbers, just to provide some context, because the graph there is in rates. Death per 1,000 live births. So the actual numbers in 2012 were 27 infant deaths in all of Minneapolis. 14 of them amongst blacks, 8 amongst whites, 4 amongst Hispanics, and 1 each among American Indians and Asians. The city's overall rate of 5.9 is better than the Healthy People 2020 objective of 6.0, so that's a national objective. But you'll see that there are groups that are above that number. I want to point out also that during the recession and foreclosure crisis, which was about, I think you can look at like 26 to 208, that number. Housing instability shows that infant mortality is really sensitive to socioeconomic conditions, where we had housing instability, which was greater amongst Black and Hispanic children under age 2, according to the 2010 census. Only 55% of Black and Hispanic children ages 1 or 2 lived in the same residence for the previous year compared to more than 80% of white and Asian children. So housing stability and infant mortality are highly related. we can stay on that. I'm just going to my next page. Thanks. When we've done a lot of work to try and address infant mortality, and I would say this is not my proudest chart. It's kind of flat. We have made progress in post-neonatal deaths, which are generally attributed to behaviors like healthy sleeping, a safe sleep environment, injuries. But we have made less progress in preterm birth, which is the leading cause of infant death in the U.S., about a third of all deaths. And this is really connected to the mother's health even before she conceived, her chronic stress, chronic diseases, healthy weight, tobacco use, high blood pressure. And many of these factors are tied to socioeconomic factors. So we all have more to do together to address this. I did want to point out that I think at end of the week before last, end of August, we finally heard from the federal government about a Healthy Start grant. We've had a Healthy Start grant since, I believe, 1999, but it was time for us to reapply for the next 5 years. Very delayed by months and months in hearing from the federal government. It was highly competitive. Many other cities that have strong programs, have been funded for years and years, were not refunded. We were. We will receive $3.5 million over the next 5 years for the Healthy Start program. Our focus is going to be singularly in Minneapolis. In the past, we've focused in Minneapolis and St. Paul. We'll be focusing in Minneapolis, primarily on women who are African American in north and central areas of Minneapolis. This grant will allow us to work with women when they're pregnant and with their families up through the age of 2 of their child. It will help us do more community engagement, more outreach, assure that there's a psychological risk factor screening, and that there's case management to connect women both to health care, but also to resources to help them meet their basic needs, to provide more housing stability and that sort of thing. This work goes on top of another major investment we have of nurse home visiting, which uses evidence-based models that have been shown to make a difference in the trajectory of the little one's life. Some of our partners working with us on the new Healthy Start grant will be the Minnesota Visiting Nurse Agency, North Point Clinic, Family Partnership, and Hennepin Health Mother-Baby Program, which addresses issues of mental well-being and mothers. The next area I wanted to focus on was youth homicide. And as you'll see, there's been a general decline. We were quite pleased that in 2013 there were no young people under the age of 18 who died in the city of Minneapolis because of homicide. Unfortunately, in 2014, there was one young man who did die due to homicide. We think we have the best chance of influencing the number of homicides for those under 18 because those are most likely to be residents here. We are also, though, interested in victims 18 to 24 because of what we know about brain development, and we know that they are still youth, they are still adolescents, their brains are still being completed, they still have many youth development objectives that need to be met in order for them to have a healthy life. This second one maybe gives you a little more sense of an overall trend of progress. This is a compilation of incidents that involved guns where their juveniles were either victims, suspects, or arrestees. And you'll see that that number has been decreasing, especially since 2006. The next area of disparities that are quite persistent are sexually transmitted infections, and the slide you have before you is for gonorrhea. There's a similar disparity when it comes to chlamydia. In 2003 and through 2008, for 5 years, we had a federal grant to do a program called Seen on the Streets, which reached out to young men who weren't connected to a lot of other stuff and addressed their sexuality and sexuality health practices. But we also heard from them that they were interested in connecting with folks around violence and talking to folks around relationships. And I mention this just to remind you how interconnected many of these disparity issues are, that they're none of them really stand alone, either geographically or topically. Some of the changes recently have to do with an easier way for clinicians to do expedited partner therapy, and so we're supportive of that. But we also see, because of the tremendous disparity between Blacks and the other cultural communities, that culturally specific strategies are really called for. Just as a frame of reference, the overall rates for this have been increasing in St. Paul and suburban areas and greater Minnesota as well. So it's part of an overall trend, but that doesn't mean that we don't need to work on it here. The next slide shows you two maps. The map on the left-hand side is the number of elevated lead cases if we look at 10 micrograms per deciliter, and that's the level at which we have the authority to, or we have in the past had the authority to intervene, to go in, to say, let us come into your house and see what we can do to modify the physical environment and get rid of some of the lead risk. Recently, with our strong urging over several years, the State Commissioner of Health has lowered the rate at which we are permitted to go in and offer more help to 5. And so the map on the right shows you how many more cases there are of young people that have a slightly less elevated lead level, but we know from CDC that no level is safe, and elevated blood lead levels impact your ability to do well in school. They have been shown to have correlations with future involvement in violence. And so we have a new opportunity to intervene earlier. It's an optional one, and we are trying to make sure that we have garnered the kinds of resources we need in order to do a good job intervening at that new level. The next slide switches focus a little bit and has us thinking about our food environment. I think it's interesting, the two bar graphs there show that the food industry is really a place of significant employment for people who were born in another country. And we raise that, we show you that because not only restaurants that are ethnically oriented food, but across the entire food industry, we have people whose primary language is not English. And without a strong relationship and two-way communication, our regulations will be less effective, and we have the potential of having outbreaks such as the last year's Ecuadorian festival outbreak, where quite a number of people ended up in the hospital. So we have started to have some focus groups with folks in the Somali community, in the Latino community, in the South Asian community, just to make sure that we understand each other's worldview of food and what's healthy and what's good. And I had a chance to listen in on a little bit of it, and it was really interesting to think about how what we think of as good and healthy, we wrap up our meat, we seal it up in plastic, and we throw it in the refrigerator, or we get it in the freezer. We think that's good and how unappetizing and unhealthy that seems to people who are used to actually looking at the animal that their meat came from and making some decisions about how healthy that food might be once that animal is butchered. And so it's these kinds of opportunities to hear from each other, I think, that will lead us to better two-way communication about how to keep each other safe as we prepare food for one another. The next slide is sort of a midpoint peek at what is going on now. We've done 4 tests in the community, and we have scheduled 4 more to end by next August. We're testing at approximately 120 different locations throughout the city for about 77 different volatile organic compounds. You'll see red dots and blue dots. The blue dots are places that have not shown levels that are higher than is healthy for humans. The red dots are places where we have found at least one chemical above that level. And so our next step, once we have completed this work, is then to work with community organizations and community members to discern what might be the source of this pollution and what might we do together with a special eye towards environmental justice issues. So it's just probably too early a peek at what there is, and they're fairly well distributed, but I'm sure we'll learn a lot more about the stories behind each of those red dots as the year progresses. I think this is nearly the end. Here we have a slide looking at youth access to tobacco. You've had a chance to listen already to the recommendations of the folks from the Youth Congress. We know that smoking rates and smoking-related mortality is highest amongst people of color and low-income populations. People of color and low-income populations are specifically and aggressively targeted by tobacco companies, and I think that came through in what the young people had to share with us. We know that smoking prevalence is much higher amongst American Indian youth, and Hispanic smokers born in the U.S. smoke at a higher rate than those born elsewhere. So we are so excited about the work that young people have done and have already shared their advice with you, and we hope that there will soon be an opportunity for you to consider action based on their recommendations. This second to the last slide is the map itself is a compilation of healthy food outlets. And a first look at it makes it seem like we got a pretty good situation in terms of access to healthy food. And that's really just the first step. So this is a map that tells us about the physical environment. Is there some food around here that I can buy? Then we need to think about the socioeconomic factors. Is it affordable to me? Is this healthy food culturally relevant to what I feel like eating? But it does support some healthy behavior choices. What's needed next then is to meaningfully engage with communities. And so the story on the right talks about an effort we had to develop local food resource hubs. And they were easily and quickly successful until we looked at the diversity, the makeup of the people that had chosen to participate, and saw that it did not reflect the diversity of the city. And so used a new model, partnering with additional community organizations to help us spread the word, be trusted messengers, bring people in. And so we have been able to bring in 350 new members through our partnerships with community-based organizations. So just an example of, you try something, it's pretty darn successful, but it's got some big holes, and then you think, well, what did I miss the first time? Too bad we didn't think of it the first time, but at least we thought of it the second time. So the final slide is back to that graphic that I started with. We as a health department try and intervene in all of these quadrants. Healthcare, we subsidize healthcare in community clinics. We We help support the Minnesota Visiting Nurse Agency. We have the school-based clinics. Healthy behaviors, we're certainly involved in like promoting comprehensive sex ed, all sorts of health education and promotion efforts in the community, STDs. We're very involved in the physical environment. And we try our best in the final quadrant, that socioeconomic factor quadrant, but that's the one where we really do need to partner with others in the city and the community, and so that we can be effective in all quadrants and make a difference and become more equitable. So that's our quick little overview.
Thank you very much. That was a wonderful presentation. And I actually know that Councilmember Yang is working on the youth tobacco issue, and I think there'll be an ordinance introduction soon. I don't see a lot of questions, and I do know that we are ready to lose quorum soon. So I'd like to receive and file that report. All those in favor say aye. Opposed? Okay, we've done that, and I think we can let Councilmember Fry probably go, but we could, that's all right, thank you very much. And I think we can adjourn the meeting, but people can stay if they want to talk more. Yeah.
Thank you, Mr. Chair. I was just curious, a lot of these factors, like infant mortality rate, for example, even the lead issue, seem to have a lot to do with access to healthcare. And I just wondered, it seems hard to unpack that, but how we're approaching the issue of inequitable access to healthcare. So, for example, prenatal care for women. Do we know how much that is a factor in some of these outcomes?
Mr. Chair, Councilmember Bender, I would say it isn't any more important in those two issues than it is in the rest. Even when there are opportunities to seek care, it isn't always, doesn't always occur to a woman that I should go in, I'm pregnant. Maybe I've been pregnant before, I kind of know the drill, or maybe I'm not sure I want to be pregnant, or maybe I didn't have such a great experience the last time I went in. Maybe I'm homeless, I just got other stuff to do. So I think you quickly see that these other factors influence even access to health care. Certainly discovering elevated levels of lead in young people is something that is often done in a healthcare setting. But if you had housing without lead in it, it wouldn't matter whether or not you drew bloods and discovered what the level of lead was. So although we want that to be discovered, we want people to go to clinics and have it discovered so that we can fix their environment, the best would be if we had environments that didn't even have lead in them.
Well, I actually wondered legitimately how much of a factor it was, and how much of these other things, which I feel like, at least I'm sure we do partner with healthcare providers, but in our position, it's easier for us to impact some of the other issues with the physical environment, for example. So thank you.
Yes, and a lot of our work with healthcare is also through the health plans, who are very interested in these topics as well. So healthcare providers in the community clinics, but also health plans, especially the parts of the plans that have the programs that serve folks on Minnesota Care or Medicaid. They're very interested in moving forward with us.
But I think two of the best things that we're doing are more directly related to healthcare. One is the school-based clinics,
Yes.
which we're supporting. So especially when you get to the teen pregnancy or the gonorrhea or some of these key things, that I think creates a real connection for a lot of youth that wouldn't, to getting access to some health advice or care and resources. And we also do the visiting nurses for, in fact, before the baby's born, if somebody goes in and gets referred and we find out about them, they get a visiting nurse, and then they get that for the first 3 years.
Usually up to age 2 of the child, so
okay.
through pregnancy, and then so it's almost
Yeah.
3 years total.
Yeah. So, and I think that's So I think we figured out, I guess it's kind of it was clever and difficult and challenging, but we've kind of figured out how to also try to impact access to healthcare too.
Yes, just to amplify your comment about adolescents, they are a special kind of betwixt and between population who no longer necessarily want to go with mom and dad to the same old place. They have a high need for confidentiality, even if they're just going for sore throats. And so a school-based approach is really tailor-made for some of the issues that they face.
Well, we're still on the air. We're still actually having a meeting. If there's any other questions or anything. Okay, I don't see any. Thank you very much.
All right, thank you.
Appreciate that. And I'm not sure if I officially adjourned us, but now I'll make sure we're officially adjourned. All right.